So thank you for joining us for tonight's webinar on patient-reported outcomes. This webinar is sponsored by our Commission of Cancer Committee of the Florida chapter of the American College of Surgeons. My name is Dr. John Rioux, and I'll be serving as tonight's moderator. I'm the Cancer Liaison State Chair and also chair our Florida chapter's Commission on Cancer Committee. Tonight's speaker is Dr. Andrea Pusic, who is the Joseph E. Murray Professor of Surgery at Harvard Medical School. She is at the Brigham, and she is Chief of Plastic Surgery and Reconstructive Surgery there. We are extremely pleased and gratified to have Dr. Pusic presenting tonight. She is a nationally and internationally known plastic surgeon with impeccable credentials. And if I had to go through her CV, then we'd be here all night. But suffice it to say, Andrea has agreed to give us the latest and the greatest on patient-reported outcomes. And as most of you know, this is a very important upcoming topic. And one of the reasons it is, gained a lot of notoriety is because of some of Andrea's work. And tonight she's going to talk on patient-reported outcomes. And without further ado, Andrea, go on ahead.
Great. Thanks very much, John. I appreciate your kind words. And it really is, it's a pleasure to be here with you this evening to share some of our experience in patient-reported outcomes in surgery. And I'm also looking forward to taking questions at the end and further discussion. My disclosure is that I am a co-developer of the BreastQ, and I receive royalties when it is used in for-profit industry-sponsored trials. The BreastQ is a patient-reported outcome measure that I will be referencing in my talk tonight. There is no charge for the use of the BreastQ in clinical care or not-for-profit research or registries. So traditionally, when we thought about our outcomes in surgery, we've relied primarily on our own perspective, on what we call clinician-reported outcomes. So these are things like looking at our complications, its morbidity, mortality data. But increasingly, we're aware of the importance of the patient perspective or patient-reported outcomes. So what's driving this shift in focus? Well, historically, just about everything we did in surgery was with the goal of saving a life. So in this scenario, the patient's perspective is really not required, nor is it even really relevant. But while we still do a lot of saving lives, increasingly, a lot of the business of surgery is also about caring and improving the quality of our patients' lives. And so this is a lot of orthopedic surgery, it's bariatric surgery, it's neurosurgery. There's in so many different ways, surgery with the goal of improving a patient's quality of life, or when the surgical options have variable effects on patients' quality of life. So perhaps quality of life improvement is not the main object of the exercise, but there are different options that have different quality of life outcomes. This is a quote from Sir Andrew Vallance-Olin from the BMJ, and he spearheaded a lot of the work in the United Kingdom around patient-reported outcomes. And he said, for patients, there must be more to success than alive or dead, complication, no complication. How often have we heard they went well, but now I'm housebound? Or he says I have a good flow rate in my graft, but I still get pain after 10 meters. For patients, there has to be more to success than alive or dead, complications, no complications. This is really the key point is that patients don't have operations with the sole goal of avoiding complications. They have other goals, and frequently those goals are related to quality of life. So this would be, I think, in terms of key points to take away from my comments tonight, is that patient-reported outcomes are increasingly important to present-day surgery. The other key point is that these aspects of outcome are now actually measurable. So while we might have realized intuitively that quality of life is important, it was only in the last decade or so that we've really appreciated that we can measure outcomes like quality of life in a reliable, meaningful fashion, the way we measure a lot of the other things that we care about in surgery and in medical research. So how do we measure patient-reported outcomes? We measure them using specially designed questionnaires called PROMs, or patient-reported outcome measures. And so while these might look like a questionnaire you might make up yourself, they're actually highly calibrated, very accurate measurement tools. And there's a whole new science around developing these measurement tools, but it is now to the point where we can count on this kind of data the same way we would think about a hemoglobin or blood pressure or urine output. Tonight, I'm not going to get too much into how measures are developed, but I would like to talk a little bit more about how we can use patient-reported outcome data in our healthcare systems and in surgery in particular. And so I'm going to think, when I think about how patient-reported outcomes data is useful in my research, I think about clinical care. And so individual care of an individual patient. I think about how we could use patient-reported outcome data in quality, so understanding what matters most to patients, and that's what we aim to improve. I think about value, so thinking about how we can optimize both outcomes while minimizing cost. And then the more traditional paradigm is also around comparative effectiveness, so thinking about how we use patient-reported outcomes data in our research. So say when we have two different options for how we perform a procedure, are there different or important quality of life differences, and how do we measure that? How do we study that? So starting first with clinical care. I'm going to share a little bit of experience with my previous hospital. I'm currently in Boston at the Brigham, but I was previously at Sloan Kettering in New York, and I'll share a little bit of our experience there. But just so that we're all on the same page in terms of what are patient-reported outcomes. So patient-reported outcomes are those reports that come directly from a patient. So things that only a patient can know and tell us about if we ask. So I think about PROs. I think about things like symptoms. So how much, if a patient is having pain, nausea, fatigue, I can't look at a patient and know that without asking them. We think about quality of life, and here we can think about things like physical function, psychosocial, sexual well-being. And then we can also think about experience, so patients' perceptions of the experience of our care. So in my previous hospital at Sloan Kettering, we opened a kind of a very exciting new ambulatory cancer surgery hospital. And as part of that, we really wanted to create it to be very patient-centered, and we wanted it to be a bit of a learning lab to understand what could be potentially best practices in patient-reported outcomes and how we could really optimize our understanding of the patient experience and use that in clinical care. So we integrated patient-reported outcomes essentially kind of through all components of the patient journey. And I'll just share one aspect related to the early surgical experience. So this was an ambulatory cancer hospital. And essentially, so patients, we did all kinds of surgeries like prostatectomies, bilateral mastectomies, and patients would go home after 23 hours. And so there's lots of advantages to these shorter hospital stays, both for the hospital and for patients to get home to their own beds. But there's also, what we realize is that this also puts an increasing burden on patients and on their families, that patients are going home with drains in, they're going home with medications that they need to be remembered to take. And one particular experience I'll share was a patient of mine that I remember that kind of brought home to me, and she was a smart young physician who was having bilateral mastectomy surgery, and she was really well prepared and had a great supportive, intelligent family that were right there for her. And surgery went really well. But when I went to see her the day after surgery, getting her ready for discharge, she was in tears. And I said, what's up? And she said, I don't know if I'm ready to go home. How will I know if something's going wrong? I just don't feel ready. And yeah, this was a healthy physician, and everything had gone really well. And it really brought home to me the anxiety that patients can feel when they're going home relatively soon after a major operation. So we got thinking about that, and we looked at the literature in other areas, and actually in the oncology literature, this is a study from a number of years ago, but I think it's important to think about in terms of seeing how patients report their symptoms relative to what clinicians. So this was an oncology study, but what we see is across symptoms like nausea and vomiting, clinicians kind of consistently underrate how patients are feeling. And I think that's, and the severity of their symptoms. And so we realized that we needed to think about really asking our patients and not assuming that we were able to look at them and know. And we also wanted to be able to provide this additional level of support for our patients that were heading home shortly after these bigger operations. So we set up the MSKCC recovery tracker, which was a system, used validated questions. They're called the PRO CTCAE question bank. And we picked those questions that about symptoms that are most common after ambulatory surgery. So things about nausea and pain and vomiting and shortness of breath and all those things you would think of. we've set up a system so that patients would be asked questions about how they were doing every day for the first 10 days after surgery. And it took patients about 2 minutes to answer their surveys. And what this did is that generated data for us. So one of the first things, this is a heat map, and it looks at symptoms by postoperative days in our initial experience with this system. And the first big eye opener was that we really didn't know what patients were feeling, and so in the sense that it was a big eye opener for our research group and our clinical team when they realized actually how the severity of some of the symptoms that patients were experiencing on day 2 and 3 and 4. And that was just in terms of us really thinking about what else we can do to optimize their immediate postoperative course in their first few days at home. It also gave us great insights about how different procedures have different recoveries in the first few days. So this is breaking this down. Although it says urology, what this really means urology is that the prostatectomies. On the plastic side, that's the tissue expanders. Head and neck surgery was the thyroids, and the GYN was the laparoscopic work. And so it also helped us really understand that, essentially all ambulatory surgery patients are not the same, and helped us to think about how we could also modify our narcotics and our postoperative order sets, and how we could expand our block program, or say paravertebral blocks for our mastectomy patients. So it really gave us great insights to things that we hadn't really appreciated. And I say this as surgeon about 7 to 10 days after surgery. And so basically all of this part of their journey is effectively over unless something went wrong along the way. So the other thing we did, though, is with these managing symptoms, is this created alerts for the nursing staff. And I would say one of the things that I think that was kind of the reason for the success of this work is our nursing colleagues really got it, and they felt that this was very much a system that they were building, clinical tools that were useful to them, because it also then generated some additional work for them, because these alerts would generate calls, or they would generate an alert that required a phone call, and quite a few phone calls, and yet the nurses really felt that this was something that was helping them do their job better. And identify unmet needs and better respond to our patients. At the same time, we all looked at it and said, maybe there's a way. What would be the next step with this? Is, beyond a lot of nursing phone calls and reassurance, is there something else that we could be thinking about? So what we did here is we started thinking about, could we give our patients some of this information back? Could we give them more autonomy to help them better interpret for themselves how they were doing? So sort of going back to my mastectomy reconstruction patient, she was saying to me, how will I know something's going wrong? If I'm feeling some pain, is it the right amount of pain, or is it too much pain? So we wondered about how we could give some of this symptom data back to our patients in a way that would empower them and make them feel and reassure them when reassurance was appropriate, or alert them that they should give us a call when that was the appropriate course of action. So with the help of with a patient stakeholder, a patient group, we started to put together these reports, and effectively we used the data from our first 3,000 patients to generate reports about what was essentially the normal curve for recovery and symptoms after surgery based on procedure type. So this is an example of a patient, say, who's had a mastectomy and tissue expander placed, and she has reported that she's having moderate pain on day 4. So the report would say, you've reported moderate pain. Moderate pain 4 days after surgery is expected, nothing to be worried about. But the curve, as you see at the bottom, is that blue line is a line of other women who've had unilateral mastectomy surgery, and the dots are how she's doing. And so it actually shows that, yes, she's experiencing less pain than might even be expected 4 days after surgery. And it also helps her to understand what she can expect, what level of discomfort she can expect at days 8, 9, and 10. So we did this this is just examples of these reports. We developed the reports with lots of patient input in terms of what patients wanted to see in their reports. Interestingly, patients, they felt that they would need to be encouraged to call, and so they wanted to make it very clear. We did not set this up as a call center. It wasn't 24/7. It was explained to patients that if they were reporting symptoms and of any severity, they should call the hospital or call an ambulance. So similarly, something like shortness of breath, that this would be something that you need to call us about. So when we look back at the development of this system, where we moved from essentially monitoring symptoms, or first measuring them and getting a better handle on it, and that allowed us to improve our systems, but through this process of then giving feedback, we did qualitative interviews with patients to sort of understand what the impact of this system was. And so early, before we had anything in place, what we were hearing from patients heading home after a 23-hour stay was, I worried about everything. I was looking for problems. And then when we put in the symptom monitoring, where they were being monitored for the first 10 days and the nurses were calling them, what we were hearing was, I felt more connected and cared for a longer time period. So effectively, kind of like, we've got you. Even though you left the building, you're still connected to us. We're still watching over you. And then when we added this extra layer of being able to, of patients getting feedback about how they were doing, we were hearing things like, I felt more in control. Like I didn't have to just wait and wonder if everything was okay. So based on that experience, we actually turned this into a study. And so we developed the program, and then we decided we would study it. And so we, with support from PCORI, and my colleague Larissa Temple, who's at Rochester now, we performed a randomized trial where we were giving patients, essentially patients either had the active surveillance by the nursing team, or they received this additional feedback about how they were doing to help contextualize it for them and give them information about how they were, what would be the appropriate course of action for them. And so this trial is actually just wrapping up. We've been very fortunate that our target accrual was 1,700 patients. We're actually, we are well over 2,000 patients now in this randomized trial, and we will be, which will be wrapping up in the fall. So, and some of the things that we are looking at in terms of the outcomes, which we'll be looking at that data, say, in the fall, is things like the unplanned return to emergency department. So, the patient who is, can we pick up on adverse events earlier by asking patients on a regular basis early after surgery about their symptoms? We are also looking at things like patient anxiety and patient engagement. So what we heard in our feedback from patients was that they felt more supported. And we're also measuring outcomes as reported by family and caregivers. Do family and caregivers also feel more supported? So stay tuned for that. I'm going to be looking forward to reporting back on the outcomes of that trial. So moving into another aspect of clinical care, so that was symptoms. Now I think about sort of how we measure quality of life outcomes. The BreastQ, as I mentioned, is a patient report outcome measure that was developed by my team. We first published on that in 2009. It was a big project to develop the measure, and it's was funded by the Plastic Surgery Foundation, and it's since become really very broadly used. It's translated into a lot of different languages. It's also part of the International Consortium of Health Outcome Measures, or ITROM Standard Outcome Set, and it's also a CMS-approved performance measure. So it's being used in a lot of different places by a lot of different people. And basically what the BreastQ is a tool that we can use to understand patients' perceptions of both the outcome and the experience of breast surgery. We have modules for breast cancer surgery, but also for other types of breast surgery. I'll share just briefly our experience at Sloan Kettering with the BreastQ. And so we introduced the BreastQ as a component of routine clinical care, meaning that all patients were asked to complete the BreastQ questionnaire preoperatively, and then we use that to follow our patients over time, and effectively with the idea of trying to identify unmet needs and be able to respond more effectively and efficiently to those needs. I'm going to share a couple of examples. So this is every time I would walk in to see a patient, and also this was also reviewed by the nurses. And I say again, our nursing colleagues were just tremendous supporters of this work, and I don't think it wouldn't have been as successful without them. In fact, I know that. But as an example, this would be a patient who's had a tissue expander placed, and a tissue expander being, for the non-breast surgeons, is a device we put in generally under the pectoralis and serratus muscles after a mastectomy to begin creating the space for a breast implant. And you can imagine that's an uncomfortable both procedure to recover from and also then subsequently. And so this would be, so the BreastQ, the way it works is it has a series of different scales that measure different aspects of outcome or experience. And so this is a patient, this is her physical well-being, chest and upper body responses. So these are questions about pain and tightness and pressure. And so you can see on the y-axis is the BreastQ score 0 to 100, with a higher number meaning better physical well-being. So preoperatively, she was at 100. And you can see at 2 weeks that really dramatic drop of her physical well-being of her chest and upper body. And then she kind of makes her way back up. So what would happen at Sloan Kettering is that patients would complete this, and then the nurses would see that 2-week drop, and that could trigger a referral to physical therapy or pain management or a host of other interventions. And at the very least, a discussion. And so we use this as a component of routine clinical care to address kind of essentially an unmet need, because a woman like this frequently wouldn't necessarily complain, and yet there are things that we could do to make things easier for her. I'm going to share with you 2 patients of mine that kind of illustrate this concept again. This is a patient who had a tram reconstruction, meaning we did a breast reconstruction using tissue from her lower abdomen. And the first graph, you see physical well-being, chest and upper body again. And again, on the y-axis, that 0 to 100 number, with a higher number meaning a patient's doing better. And this is my patient over time. And so she had her unilateral mastectomy, and then she recovered. She had a bit of a dip. You can see the 6-week numbers there. And then she kind of came back up again from a chest and upper body perspective. But I took her tissue from her abdomen. And as you can see here, there was quite a dramatic drop. And I'm seeing her kind of, you can see these are sort of every 6 months or so. And it's just, that's not just post-operative recovery, but it was continuing to trend down. And I'll tell you, I just couldn't, looking at her, I couldn't figure out what was going on. She was a little bit of a heavier woman, and I couldn't appreciate that there was a problem, but except this data was pretty compelling in terms of how she was telling me. And the questions in this physical well-being scale are things like difficulty making a bed, difficulty getting out of bed. So things that all women do. And so, and all women should be able to do. So what happened is when we got to about 2014 there, that's that lowest point, I sent her for imaging, and lo and behold, I found that I'd missed a hernia. And so she had a hernia, and we went on to fix it. And that's where that inflection point with a dot, and things improved from there. But as an example of sort of helping me identify that I really, to be able to further evaluate this information was extremely helpful. And just another example, this is another patient of mine. And so, you just heard about the breast Q, so you may, and you may never have heard of it before, but I think you could probably see at a glance that across satisfaction with breast, psychosocial, and sexual well-being, this patient of mine is not doing very well. And yet, if you saw her, if I showed you a photo, you'd say, pretty good result. And but this was, every 6 months seeing this patient, and her scores were dropping across these various domains. And so basically, and this was also a particularly lovely woman who would never have complained about a thing. And so it was only as I reviewing these scores, I said, really what's going on here? And further evaluation, I realized that she had worsening capsular contracture, which is scar tissue forming around her implants, but it was relatively symmetric. So it was kind of hard to appreciate the change over time. And yet for her, she knew something was changing over time, but for her, it was hard to explain to me what it was she was feeling. But again, this sort of prompted a further discussion, and then subsequently further discussions about what we can do for that, which can be addressed. So that was our experience at Sloan Kettering, and they've continued to collect rescue data. I'm now at the Brigham, and we're launching into sort of kind of a next level of that, and kind of bringing together both the clinical sides of things in terms of collecting data in a meaningful way and giving it to clinicians in a way that they can interpret and do something with. We're also working to give patients that information. So building on the experience that I had with symptoms. So now we're actually also creating reports that patients will find engaging and helpful to help them contextualize how they're doing, both in the short term and around symptoms, but also in the long term about quality of life. We're also building into this a platform that will allow surgeons to see, and not just surgeons, but also the breast surgeons, plastic surgeons, but also the medical oncologists and the radiation oncologists to see how they're doing. So in terms of reporting back patient-reported outcome scores in their own patients. And we're using it as a vehicle through which we will collect, I mentioned ICHOM, which is an approach to collecting standardized outcome measures. So this new system will also collect the ICHOM standard outcome set, which will allow us essentially kind of to put together both the PRO data plus the clinical data to help us better understand the quality of our outcomes and ultimately value, which I'll speak to in a moment. And then finally, our platform will also be able to facilitate research. And so that's a lot of the similar work has also come out of Sloan Kettering, where we can also start to understand in a real world experience, say randomized trials, being able to randomize patients into different cohorts, kind of in a real world experience, essentially real world experience mode, where we're changing different variables or changing patterns of practice and then measuring again. So and kind of building on the experience that we had with the PCORI trial, and realizing that when you build research and randomized trials into this kind of clinical paradigm, it actually gets to be pretty easy to randomize patients, and these kinds of trials I think can be very successful. So kind of that, I point out what we're doing in Brigham because I think it's also, to my mind, it's bringing all these different pieces together. So I think that when when patient-reported outcomes work well in surgical clinical care, that provides information that can help give us insights around quality. And it also provides information that helps guide our discussions around value, because you take the PROs and then you have to add in the cost value, and then you have the value equation. And then also finally about comparative effectiveness and the opportunity to run randomized trials. I was going to say a few words briefly about quality, value, and comparative effectiveness, kind of with that in mind. And the college has been, I think, incredibly prescient and insightful around patient-reported outcomes and how that's important to surgery, and how it's really, as I say, going back to that, what surgery once was and what surgery currently is that we are both about saving lives, but also improving the quality of our patients' lives. And so I think the college is certainly at the very leading edge of that curve and of our culture around patient-reported outcomes. And there's been a lot of really great initiatives. I think when we think about going back to the idea of patient-reported outcomes and clinician-reported, what's the optimal place to be? Well, we want to be both saving lives. So we want to be, that's the x-axis here. But at the same time, we want to be doing everything we can to either improve or maintain the quality of lives of our patients. And so when we think about quality and improving quality, I think it's really that green circle that was what we should be aiming for. Best outcomes is reported by us, the clinicians, but also from our patients. And this is an example, again, going back to Sloan Kettering. This is from urology, and this is exactly what was done. So on the x-axis here is patient's potency and continence after prostatectomy surgery, and on the y-axis rather, and then on the x is disease-free survival, as disease-free rate. So essentially looking at cancer recurrence. So when you have your prostatectomy, you want to have you want an operation that means that the cancer doesn't come back, but as much as possible, patients want to maintain their urinary function and erectile function. And so I think this is, as we think about quality and the interplay between what we've traditionally measured as our markers of quality and how do PROs come into that, I think they come in together. It's not just about now just measuring PROs, but it's the value added of also measuring patient-reported outcomes. Just a kind of a different direction with this, thinking also about how we can use patient-reported experience data to improve quality. This is an example from the again, going this back to the ambulatory surgery hospital that I mentioned in New York. So here we use the SCAP survey. So the college again has been really ahead of the curve on this work, and so the college developed the SCAP survey a number of years ago, and it's to measure patients' experience of surgery. And so when we started this new ambulatory surgery hospital, we basically had every patient that was coming through was completing the SCAP survey to give us a feel for how we were doing. And so you can picture this was a really fabulous ambulatory surgery hospital, brand new, and we're pretty proud of it. And but same surgeons that were operating in the main hospital were coming down to the ambulatory surgery hospital. We were a little bit surprised by, if you see the third line down there, that a quarter of patients were not satisfied with surgeon attentiveness on the day of surgery, and so this was worrisome and surprising, and frankly, and we were dismayed by it. The surgical community, the surgeons were dismayed by it, and sort of scratching our heads. And we took a further sort of deeper dive in terms of what exactly that meant that patients were saying. And if we look here, so surgeon attentiveness, and what it was is patients were unhappy with there was a quarter of them were expressing dissatisfaction with the visit of the surgeon before the surgery, and also then the discussions about the outcome of the surgery after the surgery. And what we realized is we created this very efficient ambulatory surgery hospital, and it was so efficient that the surgeons couldn't actually get to meet with the family before surgery or after surgery in a consistent fashion. So it wasn't happening the way in our main hospital. That just happened by routine, everybody, and there was also just more time between cases. So I use this example because I think it really gave us insight into something that we just didn't recognize was happening. And it wasn't that our surgeons had suddenly stopped paying attention or stopped caring about seeing the families. They just really, the system was so fast and so efficient, they couldn't get down to see them. And so we did a number of things that helped to improve upon that, not least of which was that we started to have essentially kind of a Skype software solution, so that surgeons could actually Skype call. If they couldn't get out of the OR to get down to see the family, they could do a Skype call and speak to the family, and the family could see the surgeon and feel they'd had that connection. And we also did some things about slowing things down a little bit, just to make sure that if that patients were able to be seen by their surgeon and felt that they had that contact as well. So part of it was feeding the information back to the whole system. But it is an example, I think, of us, of something that we otherwise would not have appreciated, but it was a very actionable, fixable problem. Other things that are happening now with that our college initiative, that college initiated, is that so whereas NSQIP has traditionally always been about our clinician report outcomes, there's a new focus on including patient report outcomes into NSQIP, and so we just completed a pilot of that work, and in building that, we sort of looked at all the ways that we can make that as successful as possible, bringing patient report outcomes into NSQIP. So, and the main one being is to enable actionable improvements. So that I think this is everything that we do in terms of collecting data should lead to something, and so that's really what the focus has been, is sort of doing all the things about having a solid platform and psychometrically making sure we're picking the right questionnaires and we're not burdening patients, but also particularly collecting information that will lead to actionable change. And so we just published in the Joint Commission Journal on the experience with this pilot of patient report outcomes in NSQIP. And this work was led by Cliff Coe, and we had a fabulous fellow, Jason Liu, who did this work during his fellowship with the college. And it was a very successful pilot. We had 17 hospitals participating, and most positive and surprising is that our average patient age was 63, and that tells, and this was all electronic, so it also tells me that increasingly, that there was always previously a thinking that perhaps older individuals wouldn't be interested or willing to do these kinds of questionnaires, and yet clearly that's not the case. Just one final example here about from a quality improvement perspective. This is a study. It was an audit about 5 years ago now in the United Kingdom, where 8,000 women completed the breast Q after surgery. So the whole country effectively was part of this national audit, and they had a high response rate. And to show you again how this data can be used for quality, this is something called a funnel plot. And so each dot here represents a surgical practice in the United Kingdom. This is patient satisfaction with their breast. So this is a breast cancer population. And on the y-axis, a higher number meaning higher satisfaction. And the line down the middle there is the average satisfaction with breasts across the United Kingdom. And the lines on either side are essentially the confidence interval. So, and meaning that if we have a lot of data on a specific surgeon, then we can have more confidence that is a true estimate of that surgeon's performance. And this was adjusted for all the things that you want to adjust for, like radiation and laterality. And they were actually able to discern some quite important differences about patient satisfaction with the outcomes of their breast cancer surgery across different units in the United Kingdom. They also looked at things about how patients felt that they were informed. So the breast Q has a scale called satisfaction with information, and it's a series of questions that again sum to 100 or 0 to 100. And here it gets at questions that sort of ask things like, did the surgeon tell me my options, or did the surgeon tell me what he or she was going to do? And then kind of on the far end, did the surgeon actually help me understand recovery, or what could I expect if all went well? And what they saw in the United Kingdom here is those 3 red dots are surgical units that were more than 2 standard deviations below other surgical units in the country. And so that means that's really that's pretty limited performance in terms of how much information patients are receiving before their surgery. But equally, it's a very actionable information, because what happened was that the information that those units were provided with the kind of information packages that the high performance units were providing with their patients. So there was a conversation between high performance groups that were really doing a great job of educating their patients and groups that were not doing such a great job, because that's a process thing, and it can be addressed. So just moving briefly on to value, I think we think a lot about cost these days, and we think a lot about value these days in terms of outcomes and cost. And I think this has been the traditional paradigm, has been that it's outcomes over cost. That's the equation. And I think increasingly what you're going to be seeing is that it's patient report outcomes, not just clinician reported outcomes, that is that numerator. And this is where ICHOM, I just point you back to the ICHOM outcome set, if you're not familiar with it, is that I think where ICHOM has been very insightful about putting patient-reported outcomes kind of not the only outcome, and I think, but in my mind, it's both clinician and patient-reported outcomes that we should be focusing on, but that but it is certainly going to be increasingly part of the equation, I think. And then finally, just a word about comparative effectiveness. So patient-reported outcomes actually kind of got their start in the research literature. And so you'll see a lot of, when you're reading studies, you see a lot about patient-reported outcomes. And I think what's important is to be able to feed that we think about these insights around clinically important issues, and that then it actually impacts on our practice. And I'll just share a study that my team published. So this was a study that I PI'd with Dr. Ed Wilkins at the University of Michigan, and this was a study of 57 surgeons, 11 centers we had, and we collected, these are all breast reconstruction patients, and we followed these patients prospectively for 2 years. And just to give more as an example, just to show you how kind of the actionable insights or the things that you might that help us understand outcomes from a patient perspective better. So we had, of our 23, almost 2,400 patients, that we had about 71% of them completed a survey, a breast survey at 1 year, and about 1,200 completed their 2-year survey, and about 2/3 of these patients had breast implants for their breast reconstruction, and a third had flaps, like tram flaps or own tissue reconstruction. And so the MROC, the purpose of this study really was to look at sort of common questions that patients ask, and then also kind of the way that we as surgeons want to have better answers for. And I think this, I'm using a breast example, but I think in many of our clinical areas that we work in, whatever type of surgeon you are, there are these kinds of questions come up, and that we don't always have an answer. And you can't answer that question based on just complications data. You need to also understand the expected outcomes of the procedure, and that's not what complications are. Complications are the things that don't happen very commonly. And so we hope that MROC would help provide some insights into that. And so just sort of in the interest of time, I'll cut to the chase on this. But so what we found is that compared to patients who had implant reconstruction, patients who had breast reconstruction using their own tissue reported greater satisfaction with their breasts, greater sexual well-being, psychosocial well-being, and also but to a lesser extent, greater physical well-being of the chest. This doesn't mean that all patients should have flap surgery, but I will tell you that it does mean that patients should, at least good patients who are good candidates for this operation, should probably have, that this is something that should be considered. And also in the U.S. right now, it's sometimes difficult for women to gain access to own tissue reconstruction, because implant surgery there's just greater access with in terms of surgeons and OR times and access. So this was information that we could share with patients, share with surgeons, and also share with different healthcare systems. Another example, just a clinical question that MROC helped focus on. Patients often ask us, what's recovery like? And I think, again, going back to sort of the symptom data, when you only I see patients, 7 to 10 days out, they seem to be okay. And at 6 weeks, they seem to be much better. So I think sometimes we don't really have, we base it on the time points with which we see patients. This was MROC data looking at recovery. These are all different types of breast reconstruction, all the different lines. But what you can see is that, so physical well-being, chest and upper body, and the first time point is preoperatively, and then at 1 week, there's quite a dramatic drop there. But at 3 months, patients are still not back up to their baseline. And so I think some of this is recovery, some of this may be morbidity. What we did see is later in MROC that a lot of this is recovered, but the recovery is longer than we think and sometimes tell patients. Similarly, I will show you the data, but fatigue was similar. That patient fatigue after surgery is probably more significant and lasts longer than is commonly appreciated. So in conclusion, the different ways that we think about how PRO data can help us in terms of surgical care. I think it's very much about the one-on-one with the patient, so identifying unmet needs. It's not about replacing a conversation with a patient in that setting. What I see it as is figuring out something I might not have otherwise known, and being able to address that in a more efficient way, actually. I think that patient-reported outcome data can also very significantly help us in quality improvement. So actionable insights, things that we can understand, things that we might otherwise not have understood from a patient perspective, and then do things about it to improve our care. I think increasingly you'll see that PROs are going to be part of the value equation. in addition to our traditional clinician report outcomes. And then I hope to see ongoing studies looking at comparative effectiveness of different surgical techniques, new techniques is something, things that are new, are they new and actually better from a patient perspective? I think that we'll see more and more PRO data embedded into our clinical trials and comparative effectiveness studies. I'll leave you with this quote, which I like, by Bill Gates. It's, "I have been struck again and again by how important measurement is to improving the human condition." Thank you, and I'd be happy to take questions.
So if anyone has any questions, feel free to type them into the Q&A box to the right of your screen. Dr. Pusic, great talk, very informative. Where do you see PRO going in terms of mobile device platforms and integrating into the EHR?
Thanks, Nicole. Can you hear me okay? That broke up just a little bit, but I think if it's where it's going in terms of mobile devices.
Correct.
I think that, the future, it's just a timely moment where we're actually also, mobile devices have just blossomed in that way. So we're already in our Brigham work so a lot of the PRO work now is happening on phones, and we've seen that and PROs and registries and different way the text messaging has really opened up a lot of different opportunities for PROs. And then I think also what we're seeing also is tying PRO data also to mobile devices and say Fitbits, and being able to sort of also track both how patients are reporting, how they're doing, but also being able to track some activity data and different data that we weren't previously collecting. So I think it's a really exciting time from that perspective.
So Andrea, this is John. I really appreciated your reference to the NSQIP value equals quality over cost equation that we're all very familiar with, and patient-reported outcomes as a portion of that numerator quality. Can you expound on that a little bit?
I think so. This is work we've been working recently closely with the business school here in Boston, and they've been very supportive. And I think so about value-based healthcare, and thinking about how we both can measure our patient-reported outcomes and also get a handle on cost. So I think that's in terms of how that equation and where that equation is guiding us. I think on the NSQIP side, we are. That's sort of the next frontier. We are currently collecting, there's the PRO data pilot, but then where that goes in terms of then being able to link that to cost is the next step.
Dr. Pusic, we have one more question. Can the data retrieved be directly imported into the EHR, like an inter-visit note, such that all providers caring for the patient beyond the surgeon can see?
It can. So different systems have evolved. Different PRO systems have evolved differently. So here in Boston, the partner system is fully integrated into the EMR. So using Epic's platform. At my previous hospital, we had it similarly integrated, but it was a standalone system that we built on our own. And so I think it just depends on what your local system has built in for you, or that you would build. But it's certainly something that can be done, and is being done.
Well, Andrea, you kind of phased out there for a second, but I'm assuming that you're back to this lecture tonight, and everyone has certainly learned a lot, and I look forward to hearing from you some of your research at the next clinical congress and perhaps even at the next Florida chapter meeting, which will be in Orlando in spring of 2020.
Great,
so
thanks so much, John.
Thank you again very much, and I hope everyone has a nice evening.